Today we're going to be discussing hyperthyroidism. This is basically just an introduction to clinical endocrinology, and we're going to be focusing on what can go wrong in thyroid pathology. So I think that the best place to start is by first of all looking at the structure and functions of the thyroid gland. So as you can see from this diagram on the left, the thyroid gland is a lobe-shaped structure which sits directly in front of the trachea and below the larynx. And it has multiple functions. For example, it's involved in metabolic rate control, it's involved in heart rate control, it has neural effects, and it's also involved in bone and muscle health as well. And it's important to understand these functions because we can basically extrapolate from them to work out what the symptoms are when things do go wrong with the thyroid. So the best place to begin with when thinking about thyroid endocrinology is by looking at the hypothalamus-pituitary-thyroid axis. So we start with the hypothalamus, and this secretes a substance called thyrotropin-releasing hormone, or TRH, which acts on the anterior pituitary gland. And then this gland responds by secreting a different substance called TSH, or thyroid-stimulating hormone. And this TSH acts on the thyroid gland and triggers it to release two key hormones, triiodothyronine, T3, and thyroxine, T4. And the most important thing about this whole process is that it's governed by a negative feedback system. And basically what this means is that if the levels of T3 or T4 increase too much, it triggers the anterior pituitary gland to release less TSH and the hypothalamus to release less TRH. And that helps to keep the T3 or T4 levels in check. So we're now going to turn towards the causes of hyperthyroidism. And the way I like to think about it is that something can go wrong with each stage of the axis. So for example, there could be hypothalamic or pituitary tumors, which directly increase the levels of TRH or TSH, and that consequently leads to high levels of T3 and T4. Likewise, there could be problems directly with the thyroid itself. So for example, Graves' disease, which is an autoimmune disorder, thyroid toxic nodules, or thyroiditis, which is basically inflammation of the thyroid. And finally, there could be problems such as external iodine or excess thyroid medication, which directly increase the levels of T3 and T4. It's worth bearing in mind that the main cause of hyperthyroidism is in fact Graves' disease, and we're now going to discuss this in a bit more detail. As I just mentioned, Graves' disease is an autoimmune disorder, and to fully understand its effects, we have to look at what happens normally. So under normal circumstances, the anterior pituitary gland releases TSH, and this TSH binds to the receptors of the thyroid gland. And this triggers the release of T3 and T4. It's worth noting that this is quite a complex process in reality, and this is just a simplified diagram. TSH continues to bind to the thyroid cells, and T3 and T4 is continuously released. When the T3 and T4 levels increase enough, it triggers a negative feedback loop to the anterior pituitary gland. And this causes the anterior pituitary to release less TSH, and that consequently controls the levels of T3 and T4. What happens in Graves' disease is that they're pathogenic B cells, and these B cells release autoantibodies such as anti-TSHR or anti-TPO, which means antithyroid peroxidase. And these basically bind to the receptors of the thyroid gland and mimic the effects of TSH. So this releases T3 and T4. And many antibodies are produced, so the process continues and the T3 and T4 levels continue to increase. Now it's worth noting that there is some negative feedback here because the levels of T3 and T4 are reporting back to the anterior pituitary gland. So the anterior pituitary gland responds just like normal by releasing less TSH, but there's actually no effect on the levels of T3 and T4, and that's because the problem's not with the TSH, but rather the autoantibodies themselves. And as a result, more binding of autoantibodies to the receptors triggers more T3 and T4 release, and this results in hyperthyroidism. Now that we understand the pathophysiology behind hyperthyroidism, we can look at the signs and symptoms which are commonly seen. So if you remember from the beginning, the normal thyroid has multiple functions, and we can extrapolate from these to work out the symptoms of hyperthyroidism. So for example, the normal thyroid controls metabolic rate, so if this increases too much, it can lead to weight loss and heat sensitivity. Similarly, the thyroid controls heart rate, and if this increases too much, it leads to tachycardia. The thyroid also has multiple neural effects, so in hyperthyroidism there may be increased anxiety, insomnia, or tremors. The thyroid also controls bone and muscle health, so if this is dysregulated in hyperthyroidism, it can lead to weakness and tiredness as well. And finally, in hyperthyroidism, there may be a swollen thyroid, and this is known as goiter. There might also be some signs specific to Graves' disease. So for example, from the image on the left, you can see pretibial myxedema, which is basically this rashing at the front of the legs. And this occurs due to the presence of autoantibodies, which we discussed earlier. There might also be thyroid acropathy, which is this rounding of the nails, or exophthalmos, which is bulging of the eyes. And if you see any of these signs coupled with the normal symptoms of hyperthyroidism, the most likely diagnosis is probably Graves' disease. So now that you observed the signs and symptoms of hyperthyroidism, how do you go about diagnosing it? Well, the best place to begin is by conducting thyroid function tests. And the way these work is that you measure the levels of TSH and T3 or T4. And basically, if your levels of TSH are elevated and your levels of T3 and T4 are elevated, it suggests that there's probably a problem higher up on the axis. In other words, from the anterior pituitary gland or the hypothalamus. If alternatively, your TSH is reduced and your T3 and T4 are the only things elevated, then it probably suggests that there's a problem isolated to the thyroid gland, and the most likely diagnosis here would be Graves' disease. Patients can also undergo radioactive iodine uptake scans, and the way these work is that you can look at the pattern to see what the most likely diagnosis is. And as you can see from the scan here, in Graves' disease there's more of a spread out or diffuse pattern, whereas in toxic nodules you can see isolated areas of overactivity. And finally, patients may undergo antithyroid antibody testing. And as we've already mentioned, antithyroid peroxidase and anti-TSH receptor autoantibodies can lead to a diagnosis of Graves' disease. Once a diagnosis of hyperthyroidism has been made, there are multiple treatment options. And the first-line treatment is usually antithyroid medication, such as carbimazole or propylthiouracil. So how do these work? Well, an enzyme called thyroid peroxidase normally adds iodine to a substance called thyroglobulin, and this is a key step in T3 or T4 production. Carbimazole works by inhibiting thyroid peroxidase and preventing this iodine addition, and this leads to reduced T3 and T4 levels. Another treatment option is radioactive iodine, and the way this works is that overactive thyroid cells take up radioactive iodine and become destroyed. The problem with this treatment is that replacement thyroid hormones may be necessary if there is overdestruction of the thyroid cells. Another mainstay of treatment involves symptomatic relief. So if you remember from earlier, one of the symptoms of hyperthyroidism is tachycardia and tremors. And basically beta blockers such as propranolol can be used to treat these. And finally, a definitive treatment for hyperthyroidism involves partial or total thyroidectomy. which is removal of the thyroid gland and regular replacement thyroid medication. So if you want to test your knowledge, we have a quick clinical case here. A 55-year-old female presents with weight loss, tiredness, and anxiety. On examination, she has a swollen thyroid gland and an increased heart rate. What is the most likely diagnosis based on these findings? So the answer to this question would be Graves' disease. And the reason why is because you can see the classic symptoms of hyperthyroidism. And if you remember from earlier, the most common cause of hyperthyroidism is in fact Graves' disease. So a follow-up question, you refer her for thyroid function tests. Has your most likely diagnosis changed based on these results? So I've included the normal values and the patient's values for TSH, T3, and T4, and see if you can find if the most likely diagnosis has changed. And the answer in this case is that the likely diagnosis has changed, and that's because the TSH value is raised at 6.5, above normal. And basically, if there's a raised TSH level, it suggests that the problem is probably somewhere else on the axis, such as the anterior pituitary gland, and that requires an MRI scan to confirm, just in case. And here's a summary slide just outlining everything we've discussed in this tutorial. If you have any questions, you can leave them in the comments below, and I'll try my best to answer them. I hope you found this video useful, and I hope to see you in the next video.